That's what we do on Fridays at 8:30. So welcome those who are here and as well on the web, on the Zoom. Today we have a special guest from UCLA. He drove very early. He came to my office at 4 o'clock this morning to be just ready for the presentation. About these superstars, we will hear more from Lolo.
Good morning, everyone, and welcome to today's Distinguished Speaker Series. My name is Caroline Menezes, and I'm an incoming PhD student at Dr. Krzysztof Palczewski's lab. It is my pleasure to introduce Dr. Michael B. Gorin, Chief of Retinal Disorders and Ophthalmic Genetics Division in the Department of Ophthalmology at David Geffen School of Medicine, UCLA, and Jules Eye Institute. Dr. Gorin is the first recipient of the Harold and Pauline Price Professorship in Chair in Ophthalmology and a member of the Vision Science Division. He holds a faculty appointment in the Department of Human Genetics and is a member of the Brain Research Institute. Dr. Gorin obtained his medical and Doctor of Philosophy degrees from the University of Pennsylvania at Philadelphia and completed his internship at the Center for Health Sciences at the University of California at Los Angeles. He stayed at UCLA for his postdoctoral fellowship in ophthalmology residency training and Jules Eye Institute, and then finished a fellowship in medical retina and genetics at Moorfields Eye Hospital in London. Dr. Gorin has a longstanding research activity in the field of retinal ophthalmic genetics, and his primary research focus is the molecular genetics of hereditary eye disorders, particularly age-related macular degeneration, retinitis pigmentosa, and Stargardt's disease. His research team was the first to identify genetic regions that contribute to AMD, which then led to identification of several macular degeneration genes by multiple scientists. He continues to conduct research in these areas, as well as in the biology of ocular pain and photophobia. Dr. Gorin was a founding director of the Center for Human Genetics and a founding senior associate of the Center for Biomedical Informatics at the University of Pittsburgh. Dr. Gorin has received numerous awards and distinctions for his substantial contributions to the field, including being inducted into the Omega Delta Honor Society for Public Health, the Lou R. Wasserman Merit Award, and the Senior Scientist Investigation Award from the Research to Prevent Blindness Foundation, just to name a few. As a full-time faculty member at the Jules Eye Institute, Dr. Gorin divides his time between patient care for diseases of the retina, research into genetics of inherited eye disorders, and training young ophthalmologists and medical students. Without further ado, it is our pleasure to have Dr. Gorin present his talk for today, titled Exploration of VHL-related Retinal Hemangioblastomas.
Thank you for that kind introduction. I sound much more accomplished than I feel. I generally don't like to talk about things more than once, or I like to get into new topics. You'll notice you mentioned my interest in retinal dystrophies and macular degeneration, and I'm not going to talk about those today. And this work is more preliminary, but what I want to kind of convey in the span of my career is that I've really had very diverse interests. And I see that this room, which is very exciting, has a lot of younger people in it. I won't say young, that's kind of patronizing, but certainly younger in the sense of their careers where they're looking at their trajectory. And I want to always encourage you to consider to be opportunistic, to look for opportunities and questions that you think have importance. My involvement in this field of von Hippel-Lindau disease really started when I was at the National Eye Institute. And I was very limited in what I could do. And I was approached by a group that was trying to find the gene for von Hippel-Lindau disease. And they said, we need an ophthalmologist to look and see who has stuff. And I got started with that. And for 3 years, all I saw was von Hippel-Lindau patients at the NEI. And it really put me on a path of wanting to understand and how to treat patients with VHL. And so this has been not a minor, but a long-term sort of interest of mine for a long time. And when I had the opportunity to get involved in some research with this, that's what we endeavored to do. These are some of my disclosures. I wish I were paid for most of these, but that's not really the case, actually. In terms of talking about von Hippel-Lindau, some of you are probably not familiar with this disease. It's not very common, but it is truly devastating to the lives of those who have it. It is a cancer predisposition condition, and most people, it's passed on in a dominant fashion where they have a single mutation in the gene, though there are cases of spontaneous von Hippel-Lindau. And what happens is that they then get a second hit, which is, of course, that famous hypothesis, and then develop lesions. The prevalence is fairly low, 1 in 50,000, though in California, there's a fair number of people. And I was grateful enough that when I was in Pittsburgh, there was an internist who literally devoted his entire life to studying one VHL family and found about 2,000 people within this pedigree that he eventually brought these people in. And it was life-saving for a number of individuals. The age of diagnosis can vary depending on if the person's at risk. We can identify it obviously genetically, but there have been people who only developed manifestations very late in life. Retinal hemangioblastomas, though, are a major finding in this disease. Up to 2/3 of patients will have a retinal hemangioblastoma, and these are vascular tumors in the retina, which you'll see pictures of. And there have been reports of them in as young as 3-year-olds, so we start surveillance very early. I'm part of the group that has developed the kind of guidelines for watching these patients over time and when you should intervene. There was a tendency, and there still is among many clinicians, to look and say, oh, there's a tumor there, and then go, well, we'll see you back in a year. And it's like, well, what are you doing? So to watch them, but now we've really come around to recognizing that when you see a treatable lesion, you treat it when you can. You don't wait for it to grow, because that doesn't make things better. But we've had limitations for some time. And what I'm going to talk about is kind of how we're trying to move the basic research forward. And we're still at its infancy, really, to make this work. And also at the clinical level. As I said, over 2/3 have retinal hemangioblastomas, and patients can have anywhere from one isolated lesion to like an eye peppered with them. We don't really understand that very well. They vary in size. When you actually see patients with this and you start to learn the disease, you can recognize hemangioblastomas that are as small as 250 microns, which is about the size almost of a microaneurysm. Ironically, most ophthalmologists, again, don't know that because the textbooks always show the big tumors that are really impressive. And so there's a real bias among in the education process that people don't know what they look like. The histologic analysis of the tumors has been very interesting, because the loss of heterozygosity does not occur in the endothelial cells, even though these are vascular tumors. Just to show you real briefly. So here, this is kind of the classic picture that you would see in a textbook. Large dilated arteriole and a draining feeder vein with this kind of globular mass that has vascularity. Here's a fluorescein angiogram showing how it's contiguous with the blood flow and it fills with blood. And yet you can have tiny little lesions as well. This slide on the histopathology is to remind me that, to talk about the fact that the loss of heterozygosity is really in stromal cells and not the vascular endothelium. And we're kind of still trying to figure out what that cell is. And that's kind of where we're trying to head with our research, just to give away the punchline. How do we treat these things? Well, if they're small, you can use a laser. Often a yellow dye laser, which is absorbed by blood, is typically used. People use freezing to try to do that, though it has problems in that it does a lot of retinal damage and potential exudation. And the reason I'm pointing these techniques out, I know many of you are basic scientists, but in terms of the motivation for doing research in this field, it's to point out that the treatments are crappy. And we need to do better and be more effective. FPAL is a treatment that I actually learned as a fellow when I was at Moorfields, and have used very effectively over the years to treat fairly large lesions. And it's very simple. You just inject fluorescein into the individual, the dye goes through, fills the tumor, and then you use a blue-green laser where the the fluorescein absorbs the energy and you get enormous uptake into the lesion. And with that, you can penetrate much more deeply. You can do slow, deep burns. It's not as painful for the patient. And you can do it in a staged way. So you don't try to have to, it's not like cryo, which is extremely painful. And you really want to do it once and be done. But in large lesions, you can lead to a lot of scarring and damage. We have a couple of surgeons at UCLA who really are very good with the vitreoretinal surgical approach. When we see vitreoretinal traction and detachment, that really becomes one of the few ways that we can handle these lesions. But with multiple lesions and extensive leakage and scarring, none of these methods work well. So I've been very effective over the years in treating a large number of patients. At the same time, I'm constantly reminded of the limitations. So we want to understand the biology underlying retinal hemangioblastomas. What are those foamy cells? And can we block those cells from signaling the vascular endothelium? Before I came to give a talk, Christoph and I were talking really briefly about what causes the cell death in Stargardt disease. And he's pointed out to me that there are metabolic ceramide pathways that we didn't really consider very well in our hypothesis. We started with a hypothesis of what's going on and we just sort of follow it. We need to kind of take a step back and do the basic biology here to try to figure out what's really what pathways the loss of the VHL gene is initiating angioma formation. And that may or may not be distinct from the process of the propagation. So again, taking an analogy from another disease that I've studied, age-related macular degeneration, the genetics that may underlie the initiation of age-related macular degeneration may not be the same as the genes that affect the prognosis and progression. And they may be in common with other diseases or may be distinct. So again, with VHL, we have a ways to go. The problem is, of course, if you delete both copies of VHL in an animal model, you end up with no animal. But we are not the first to think of ways of introducing the genetic lesion specifically in the tissue of interest. So Emily Chu and Chi-Chao Chan, who is a wonderful pathologist at the NEI, were exploring this also at some time. And what they would do is do deletions with a Krelok's approach to try to generate a VHL-like lesions. And they got some early kind of hemangioblastoma-like lesions in the mice. And we thought this was a great tool, and we decided that we would do it a little bit differently in that we would take the animals that had LOX elements placed into the VHL gene, use the Krelok's technique with an adenoviral vector to then induce at any time in the lifespan of the mouse lesions in the retina. Because lesions can form at any age in humans, we should be able to do the same. And so we constructed we purchased actually a very simple AAV vector to go into the eye and started doing injections. And initially we had some pretty kind of interesting occasional positive results. We'd see these sort of vascular changes, but it was very erratic. Now, again, in the human, you get people who get one tumor that develops very late in life, or you'll see some cases where multiple tumors. We thought we should be getting a much more robust response. And we weren't really sure why. I mean, the AAV we were using seemed to be a reasonable choice, but we would get enough that it was tempting, but not very definitive. And what we've done more recently, as I said, is we've now tried different AAV serotypes, which, by the way, in and of themselves have certain tropism with different cell types in the retina. And so give us an opportunity to start thinking about what cells are being involved. And what this slide basically summarizes is that we found that of the 3 serotypes we used, AAV6 was clearly the most efficient at generating these hypervascularized areas. We don't expect it to look exactly like isolated hemangioblastomas, because in the human, it's a second hit that occurs spontaneously. And here we're inducing knockout of both VHL copies in a large number of cells. So we're going to see a fairly vast, a very widespread area of vascular abnormalities. But we have been able to now reproducibly do this with AAV6. And this has given us an insight that we really do have to sort of hone in and figure out which cell type is involved. Again, the punchline is we don't know yet, but we're working this out. And the histology that we see, you can see this particularly, let me see if I can show you here. The AAV2 and the AAV6 really show this kind of hypervascularity and complex irregular formations forming in the retina that we believe are precursors of hemangioblastomas. So the proliferation is definitely a vascular one, but it's being induced. These are not the cells that are actually losing VHL express, well, they may be, but they're not the ones that are triggering it. One of the things that we found is that microglia are clearly activated in this process. And I think one of the most exciting things we find was indicated by this arrow here, which is that the amoeboid form of the microglia, which really represents an activated form, are very highly prevalent in the retinas of the animals that are affected, that we essentially have made affected with the AAV induction. And so we think that microglia may play a role. Now, are they the initiators? We don't know, but it's tempting because if you think about it, if this was a vascularly based lesion, it would be, why wouldn't you see it throughout the entire vasculature of the body? But we don't. Hemangioblastomas are only really seen in the CNS and spine and in the eye. The other tumors that are caused by von Hippel-Lindau disease, the big one that we worry about the most is renal cell carcinoma, because that kills a lot of these patients. And also you can get endolymph tumors, which are benign but problematic tumors that can cause deafness and balance issues. So what is unique in the niche of the vasculature in the CNS? Well, clearly glial cells are one, and the microglia are another, because they populate in those areas. So we've been very focused on looking at the microglia, and our hope is that we will be able to look at this soon. The person who's been doing this work with me is Dr. Anna Matinia, and though some of you know of her, she's actually literally right now moving. I mean, I think she just set her home in Houston and is going to be setting up and taking all this with her. But she has done a lot of this work, and the next step really is going to be to look at the cell specificity by isolating microglia, doing the genetic modification of them, putting them back in, or ablating the microglia. Because you can imagine that there could be a situation where if you can find a specific cell type like this, that is the one that's vulnerable, we could do microglial ablation and repopulation in a way that could prevent tumor formation. So that's really what's motivating this. So our working hypothesis is really kind of at the moment focused on the microglia, but we understand that other glial cells, astrocytes, and Mueller cells may play a role. But we really need to get at the fundamental question of why are these only vascular tumors forming in the nervous system? Clearly that niche is very, very important, and we need to be working on that. So where are we with this today? Well, we have a robust process finally. I mean, we had initially gotten a very poor but limited response. Now we've gotten to the point where with the right AAV2, we can induce lesions really comparable to human retinal hemangioblastomas. The different serotypes are a clue, but obviously we have to go through and work this out and do cell sorting as the like. And single cell sequencing will probably be invaluable, because once we have a cell type, we can use the cell-specific transcriptomics to really start to talk about which pathways are being activated and do that basic biology. Because the presumption has been, and I'll show you where the VHL gene is in terms of the hypoxia-inducible factors. We don't really know that the process is limited to that pathway. There can be other kind of processes that are going on that we need to still look at. So we're trying to take a very agnostic approach. And I think that that's also very healthy to take these descriptive studies and really transfer them into having hypothesis testing approaches. And that's what you're doing with a lot of the work you're doing now as well here. But that's something that we all have to keep in mind, that at some point we have to move from description and associations to trying to really test causality by manipulating the system appropriately. So once we do that, we are hoping that we can move ahead. As I said, we're in a delay at the moment because of her move, but our plans are to keep this going and to really lay a foundation so that we can start to then look at the possible therapeutic models. So I'm a clinician, and so I also, as I say, treat a lot of these patients. And we've actually, in the last couple of years, undergone a major breakthrough, and I want to share it with you. This paradigm shift was a drug called bazultofan that was developed to bind to the HIF factor so that, and I'll show you the pathway, to block the induction of the angiogenesis by VHL. And in this paper that came out, they talk about the responses of tumors in the CNS and in the spine. The renal cell carcinoma was actually the motivation for really developing this drug. And ironically, they were getting response rates in about the 65% range, which was considered spectacular for cancers. But there was this one little comment in the paper, which is when they looked at the retinal hemangioblastomas in the eyes, and that was done primarily by Emily Chu, since they looked at the patients who were being worked on at the National Institutes of Health, that 16 of these lesions all showed improvement at the time of cutoff. And I can tell you that we were really clamoring for this drug because we have a number of patients where we are overwhelmed by the complications of the lesions and we can't effectively treat them with any of the technologies that I mentioned earlier in therapy. The lesions are, for example, right on the optic nerve or right in the macula, and any effort to treat them with laser or with cryo or even surgical ablation would be devastating to the integrity of the remaining retina. So this is just to show you where the bazultofan works. It binds to HIF2, it binds to HIF2 alpha, which blocks the dimerization, and thus the activation of the hypoxia response genes that trigger angiogenesis is blocked. Now, if that's really where it's working for the initiation of tumors, we don't know. I just want to point out that we don't know if this is going to stop tumors from forming. We just know that it would hopefully, just like we use anti-VEGF drugs for angiogenesis in AMD and other conditions, we're blocking it at that step. But it's been really quite dramatic. So this is just to show you, most of these pictures are from my patient, and actually, just as a little aside, they're all members of the same family. So you're going to see pictures of the mother, her son, her daughter, because this whole family, and that's one thing about von Hippel-Lindau is that you don't treat individuals, you treat families. Because it's dominant, you get multiple generations. You get the psychological trauma of it being visited upon generation after generation. But in this case, what you see here is an OCT cross-section through the fovea. And this person, you can see these black spots here, for those who aren't familiar with looking at OCTs, represent intraretinal fluid. So fluid between the cells that is leaking because of the hyperpermeability of the vessels in the tumor, which is actually out of view of that OCT. As a consequence, you can see the distortion of the retinal anatomy. When we do laser, you see two things in this next cut. One is you see these little bumps on the surface of the retina. This represents epiretinal membrane formation. And one of the things we don't talk about very much is these lesions, even if they don't leak or bleed, are constantly releasing growth factors into the vitreous that are stimulating the proliferation of glial cells, as well as RPE, but glial cells, to form epiretinal membranes. And those epiretinal membranes can be devastating. What?
Alan, can you see slides?
We're okay on this side.
Because there was one question whether people can see the slides. Alan, Dr. Taylor.
Hi, Alan.
Yes. Hi. I can see the slides, no problem.
Okay, sorry, Michael, sorry to disrupt you.
No,
no. But there
I
was
can
a
do a
one-
shout out to say hi to Alan.
Hi,
Uh,
Michael.
So what you're seeing here is that this is a consequence of both the disease and the laser, because the laser stirs up inflammation as well, right? When you kill tissue, you stimulate a migration of macrophages to clear out the cells that you've killed, and you're going to stimulate epiretinal membrane growth. So what you see is after multiple laser treatments, the fluid has accumulated even more so. The retina, the fovea now is completely distorted and can't be well recognized very well, and the vision is dropped. Now, this patient was then placed on bisultafan, which, by the way, is remarkably well tolerated. The most common problem it causes is fatigue and anemia. But you know, we've been giving it now. This I forget which patient this is, but we've been giving it to a 12-year-old with really very good tolerance. 8, 9, and 10-year-olds. So you can see that and the lesion that's causing that fluid leakage is not treated by the laser, okay? So the increase in edema is due to the inflammation caused by the laser probably and the proliferation of the epiretinal membrane. But just putting them on bisultafan allowed normalization at the level of the fovea, and even though there's persistent edema, the vision has returned to 20/20. This is one of the few published papers now that came out in 2022. And what I want to highlight here, you can see on the left, the vascularity of the tumor. You can also see, as I've already pointed out, it tends to elicit a fibrotic reaction, a fibrous proliferation, which, by the way, limits the effectiveness of standard laser. Because once you have a white surface, the absorption by laser is very poor. But if we infuse it with the fluorescein, like I typically do to treat these, the tumor fills up with fluorescein and the laser is absorbed all the way through. But you can also see these feeder vessels, these dilated vessels here. And when the person was put on bisultafan, you can see how the vessels became less dilated. And that's one thing I will also, by the way, I want to impress upon you, and that is the dynamic nature of the retinal vasculature. It is very responsive to the tissue demand, very much like the vessels in your muscles. You know, if you put your leg in a cast and you have atrophy, the vessels going to that muscle will become attenuated. If you can restore the muscle, then the vessels will redilate again. So watching the vessels change is a good clue as to what's going on. But one of the things I want to point out is you notice that the tumor never goes away. And that's one reason why I think the ophthalmologist saw 100% response and the other doctors didn't. Because in a sense, we see the properties of the tumor changing because we can visualize it so well. But when you're monitoring a renal cell carcinoma or hemangioblastoma in the brain, you are looking at the structural imaging, which doesn't really tell you about function. And unless it shrinks, you don't know that it's regressed. So I think that's part of the issue why we saw such spectacular results. This is in the 19-year-old son of that patient we saw before. And you can, I think here you can see this darkened area here is where there's fluid and edema. And you can see that initially it looks like it got a little bit worse, but then gradually over time, his vision has recovered back. And you can now see the normal foveal contour here with just a small amount of fluid. So we first started with the use of this drug in cases where we couldn't treat the lesions. So we treated it with people who had these peripapillary lesions, because up till then, you just watched them lose sight. I remember very vividly as a resident at UCLA, so this is a long time ago, going to one of our conferences where all the retina specialists were talking about a patient who had bilateral hemangioblastomas on the optic nerve. And they literally just showed the chronology of the person going blind because they had no tools to deal with it. So bisultafan has been really a game changer for us. But it also tells me that we have, as I'll show you, more to do. This is the same individual, and just you can see the change in appearance. So this is the optic nerve, and you can see how reddish it looks. And by the way, this is one of the problems, that the tumors on the nerve don't look like the tumors elsewhere. And so many clinicians don't know what they look like because they don't put them in the textbooks. So I've had occasions where I've examined patients who had been examined by an ophthalmologist within a few months before me, who said there was nothing and they had a hemangioblastoma on the nerve that was clearly obvious, but not to someone who looked at it only from textbooks. You can see by that they started in December 18th, 2021, and by 11 months later, the vascularity had gone down, and noticed that the tissue next to the nerve had become more fibrous. So that fibrous component persists and can be a problem again through life. And we've continued the individual on the drug, and you can see that here as of June 2023, I put dates in because I want you to see this is fairly recent experience that we have. The edema in the retina has gone down. We saw the OCT a minute ago, and there's just now this fibrous tissue, but the tumor is still there. So the obvious question you're going to say to me is, well, what happens when you stop the drug? We don't know. We're kind of running scared. We're in one sense, we're afraid to keep it going indefinitely. And I work with the urologic surgeons because they're really using it for renal cell carcinoma, as to how long we should go and when we should stop and what we're going to do. And that's actually one of the clinical research questions that we're trying to grapple with. How do we set up an appropriate protocol to look at what happens when you have a responding patient and you're then going to make a decision to take them off the medication? What's going to be the indication for putting them back on? What other strategies can we use? And that's an unanswered question that I continue to grapple with my colleagues. I'm sorry, this is the mother of the two children that I've shown so far. You can see that she actually had edema that caused us a mild detachment of her fovea here, subretinal detachment and fluid. You can see this is a heat map of her OCT showing how thick the retina is, white being the thickest that it actually registers on the scale. And you can see her entire macula was swollen. She was started on the drug and literally, but less than a month, this is the response that she had with recovery of her fovea and recovery of vision. So it can be really quite dramatic. And you can see that even 7 months later, the amount of fluid is still going down. This area of green here shows that the retina has actually thinned. That's a difference map from the prior one. So it's showing that there's a response that continues on for quite a long period of time. But we don't know, again, what's optimal at all. This just shows the lesions changing on the optic nerve of her. So here it was beforehand. By the way, I put in this larger picture. You can see this dilated feeder vessel. And once she was put on the drug, it also made the peripheral hemangioblastoma shrink, and the collateral vessels went down as well. So we've already been using this. As I said, we started with the lesions on the nerve that we couldn't treat at all. But when we realized that if you put the patients on this drug who had peripheral hemangioblastomas, it really changed their biology in such a way to make them far more treatable. You saw in the earlier slide that when we had the patient who had multiple lasers, you had that epiretinal membrane and increase in edema. Now, if we pre-treat them with basaltofam and treat them with laser, we get much less of that. And so we now feel that we have an adjunct therapy approach that didn't exist. And this is all in the last year and a half, 2 years. This one is a case, it means a great deal to me. This is a very emotional case for me. This is a 12-year-old little girl that I'm treating now. You notice the date of March 2023, and I just treated her again actually last month. You can see she's got multiple lesions. There's one here, 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 and I think I missed one. That's most of them, and that's just her right eye. Now, in the past, I'll be perfectly honest with you, with treating this kind of patient with just the laser, I would have had a real challenge because, first of all, she's 12. She doesn't really like this. I'm injecting the dye into her arm. I'm shooting a laser, which you do feel, by the way. She does not like this. And if I had to treat her, if I put the timing between treatments, like 6 to 8 weeks, I could easily reach a situation where I couldn't keep up. The lesions would be growing faster than I could knock them down. But by being on Bazultafam, it gives me time. So the initial treatment that we did was just to create a boundary. You can barely see it, but there's light laser burns around the bigger lesions. And that's something that we developed a number of years ago to prevent, if they do bleed and exudate, so that they don't, it reduces the likelihood that they're going to go right towards the central macula. We don't do it encircling. We leave it open at the anterior part, so that if it leaks and bleeds, it'll go away, hopefully. I don't know how well those vitreoretinal adhesions really work, but that's what we do for retinopexy, and it seems to be helpful here. And then you can see the treatment going on at different stages while she's on the Bazultafam. And that the lesions are becoming less vascularized and smaller. But I also want you to see, again, this fibrosis. And this is what I'm talking about. We really don't understand what's triggering that. Part of it may be the laser creating inflammation, but even in patients who have untreated lesions, there's a certain amount of fibrosis that occurs. And we don't have a good way of handling that. She may very well end up having to have vitreoretinal surgery. But if she has vitreoretinal surgery at a time where all her hemangioblastomas have been destroyed, the odds of success of that surgery are much, much higher than if we have to do the surgery while she has active lesions that are leaking. This is just to show you, oh, it didn't zoom over very well, just to show you all the different lesions that have been ablated or have been reduced. So this is one case where you see, without the Bazultafam, I would be really chasing all over the place trying to get this. And this is just to show you where she is. The most recent was from September 12th, so 2 weeks ago, less than 2 weeks ago. And you can see the dramatic change that's occurred, how we still have activity of this lesion here. You can see the dilated vein here, and how they become normalized. You can see the lesion that was near her macula, or in the temporal macula, has been ablated. We've now gone, so in this period of time, which has been almost a little over 2 years, we went from an eye where I was worried that she'd lose the eye to now I can almost guarantee her vision for a lifetime in this eye. We're not finished treating her. She really still hates to see me. But it's understandable. We let her do her crying, and then we take our time and we get it done. But the truth is, I feel like we've come a huge way in our effectiveness of treating this. But you can see this is what motivated me in the first place to study von Hippel-Lindau. Many of you come into areas of research with just a natural curiosity, which I think is really important in vision. But some of us who are clinicians are very much driven by the motivation to do something for our patients. And that's really what we've been striving to do. We still need to do better, because if we are at the stage here where I'm going to have to now have her watched for the rest of her life for this fibrosis and scarring, that's, you know, another health burden for her and for our system. So basically, what I wanted to show you was what motivated me to get involved in looking at von Hippel-Lindau in the first place, to kind of reaffirm the fact that we have a long way to go with the biology. There's a lot that still needs to be done. This is where single cell biology and transcriptomics and proteomics would be helpful. And we are on the verge of having a good animal model. What, is there something wrong? Hands are up. What? Want to think something? At the same time, we're seeing clinical advances that are giving us more tools for these patients. And for the renal cell carcinoma, I don't know how many of you are aware, when they first started, renal cell carcinoma is what really kills these patients. The brain and spine lesions are what give them disability. In the past, with renal cell carcinoma, they would do a nephrectomy. They would remove the kidney, and then they would go on dialysis, and then they would get transplants. Now, the urologists have become really good at doing segmental nephrectomies. So they sort of whittle away at the tumor. But as a result of Bazultafam, they can do this in a far more selective and controlled way. But we have a long ways to go. But in the eye, we really have no good tool for preventing development. You okay? I'm wrapping up in just a second, so we have time for questions. We do have guidelines for long-term surveillance, so clinicians should know what to do, but I have to tell you that almost every patient I see tells me that the ophthalmologist who sees them has no clue. So it's ironic that even if it's on the board exams and everything else, because of the way we teach it, they come away not really knowing what they're looking at, which is unfortunate. And we obviously need therapies to prevent incidents, because if you can stop something from being a problem, and this, by the way, is the same strategy with AMD and the same strategy with inherited retinal dystrophies. If we can intervene at the very earliest times where the cells have not undergone cell death, where you've not had remodeling of the retina, where you've not had the development of secondary complications such as choroidal neovascular membranes, our potential for therapy and making a lifetime change in quality of life is much, much better. So whenever you're studying any disease process, always in your mind think about initiation versus progression. And they may be related, but keep an open mind that they may have disparate elements. So I want to thank you for giving me this opportunity. I look forward to talking to many of you. As you've heard, I have very diverse interests. And so I'm very excited to hear from what you're doing here at this amazing and dynamic institute. Thank you.
We have several questions. Let's start with Dr. Clausen. Henry, are you there?
Can you hear me?
Yes.
Okay. Wonderful talk, Mike. I think this is really fascinating topic. You mentioned microglia, which I think is a great candidate. I wonder about your thoughts of potential role for astrocytes.
I think astrocytes have to be considered in the equation as well. I have a bias because I think microglia are really cool, but I mean, astrocytes definitely can play a role. We have that cell type in the CNS and in the spine as well, and they could be just as much a component. As I said, the AAV serotypes, it turns out we've talked a lot with my colleague at Duke, who's really into microglia, and which serotypes tend to transfect microglia have not been really well studied, but we're going to look at the astrocytes as well.
Great, thank you.
In line of the same question, wouldn't it be better to have transgenic mice with reducible expression in different cell types? Because the AAVs are not going to...
Well, they've done that a little bit. Chichak, and that we agree, we're moving that way too. They had tried that and in fact had found that certain cell types didn't cause the tumors. So there's been some efforts in that, but we need to do more, because getting astrocyte-specific expression has not been done. But they've looked at, for example, photoreceptors and RPE and specific Crelox activation, but we have not. But that's actually another whole approach. There's actually a lot of strategies. We have such great toolbox now from a molecular biology and molecular genetics standpoint in terms of getting cell-specific manipulations at different stages. So yeah, that's obviously a really good approach.
Yeah, so kind of going off of that question as well, in terms of like cell residency and what cells are contributing to these tumors. Do you notice any like accumulation of immune cells from circulation as well, and like establishment of residency within these HBs?
So you're talking primarily about macrophages that would migrate.
Macrophages, T cells.
We haven't really done that. We've looked, as I said, with microglial markers, which often cross over and do mark macrophages as well. I mean, one of the questions is, are we looking at a proliferation of intrinsic microglia, or are we looking at macrophages that migrate in and then behave? At the moment, we think it's the former, but we really don't know. One of the strategies, there are ways of ablating microglia so that we can actually then ask the question, will cells coming in do it?
And do you think there's some sort of crosstalk between like parasites or endothelial cells that are actually causing fibrosis in those tumors?
I don't know if the parasite and endothelial, there undoubtedly has to be crosstalk between parasites and endothelial cells in order to get angiogenesis
But
and
maybe with the immune cells as well, or?
could well be. No one has actually identified an immunologic component, a B or T cell component with VHL. But and whether that's an initiating process would be less likely because that's ubiquitous in the body. But at the same time, whether that could play a role in progression, see, again, that's dividing up incidence and progression. You may be absolutely right. Certainly an inflammatory component could contribute in some way. And certainly the B and T cells could play a role in that process. I don't think in initiation, but I think in terms of the progression, yeah. Hey.
All right, Adam.
Thank you so much for a great talk. I have a question. Was anti-VEGF therapy ever considered as a adjuvant therapy?
So anti-VEGF therapy, it's, you bring up a good point. People have tried it. And you will find the isolated case reports where someone goes, oh, look, they got better. But actually, those of us who've done it in a more concerted fashion, and Emily Chu, who's actually done a kind of clinical trial, a small one, came away saying it doesn't work. By itself, it really is not effective. And I think that has to do with the fact that you're dealing again with such a downstream component of the process. Once the disease gets initiated, suppression of VEGF just doesn't seem sufficient. And the minute you stop it, of course, the lesions become active again. But we've tried VEGF as an adjunct, like using Bazol, and it wasn't anywhere of any great benefit. So that was an interesting part. And that actually is part of the reason why I keep thinking we have to be more open-minded for pleiotropic effects of the VHL gene.
One more question. So
Sure.
was the Bazoltafam ever considered for other macular edema therapy?
Wait, say that again.
Like, was it the Bazoltafam, was it ever used for other macular edema indications?
No. First of all, Bazoltafan, I didn't show you the price. Price is $30,000 for 90 pills, I think. It's pretty staggering. So in order for us to use this drug, and I have to give credit to Brian Shook, which I want to acknowledge him. He heads our clinical center for VHL, and he has really put into place a whole process by which we have to petition the insurance companies in order to get coverage. We can't just use that drug. I don't think that it's, macular edema is an incredibly major part of my practice. And I feel that the way that I treat it is very much based on what the etiology is. So if it's a macular edema from an inherited retinal dystrophy, I see that mainly as a dysfunction of intracellular fluid transport. And we treat that with carbonic anhydrase inhibitors. Now, some of those patients have inflammation after surgery, post-surgical macular edema, and then that I treat with anti-inflammatories. If it's due to vascular hyperpermeability, such as in a vein occlusion or AMD or myopic degeneration with a net, that we treat with anti-VEGF. I have some patients who have a combination of different ones, like central serous, which is another disease we could talk about. I've been doing work on that. And that's a different strategy. But by dividing up macular edema into getting away from just looking at fluid in the retina and asking the question, where's it coming from and why is it not going away? I think we can actually be much more strategic in our approach. And I wouldn't think of Bazoltafan as being particularly the best option anyway. But at that price, it would be staggering.
All right, we have more questions. John.
Great presentation. I was wondering if these unidentified cells could be any sort of progenitor or maybe even neural crest derived cell, or that may be directing where the vasculature needs to go in early development?
Interesting question. I definitely could be. I don't know that we have an answer to that. Maybe someone here who knows more about the distribution of those neural stem cells in the retina can answer that better for me, because there is a definite distribution of where these tumors are. And when we see secondary later developing tumors, they're often near where ones were originally. You saw examples of a person who had clusters of them, and then there's other people who have only an isolated one. Neural progenitor, maybe. I mean, certainly with the renal cell carcinoma, we think it's a renal cell that's undergoing the change. We're not attributing it to another cell type. So I guess that has to be considered. Do you have any information on the distribution? Anybody here? I mean, I'm open to learning more about this. I mean, it's definitely worth considering. The only thing is, I've seen new tumors develop in people in their 50s. But presumably you still have retinal progenitor cells even then. I guess it could happen.
We have anxious comments from Tony. Tony, this shouldn't be an easy question. Tony.
Tony.
Yes, Michael, congratulations. What a wonderful presentation. And to my mind, it shows the importance of having basic scientists, clinicians to investigate diseases, because you can, in the laboratory, quote unquote, cure the disease, but in the patient, it's a very different thing. And I am going, unfortunately, the retinal fellows, the clinical retinal fellows are probably not seeing this presentation, but I'm going to encourage the retina service to have them all see it, because I think it's the kind of thing that they need to see in order to stimulate any of them that want to do the same kind of research that you've done. Congratulations, Mike.
Well, thank you. As I said, for me, I appreciate those who are true basic scientists who want to understand fundamental principles. Wayne Hubbell's a good friend.
We have a comment also from Alan.
Yeah.
Alan, are you there? Let him get his act together.
Any other?
Caroline.
Hi, Dr. Gorin. Thank you so much for your talk. How do you foresee the future therapeutics for hemangioblastomas? Do you think that the future lies more in targeting cellular components, or do you think that maybe genetic approaches, since the VHL gene is well characterized?
Well, obviously, there's different stages. So one is, of course, it's an autosomal dominant disease. And as a geneticist, and I see myself as a clinical geneticist, not just an ophthalmologist, we have the opportunity to obviously impact families and reduce the incidence within a family by family planning and strategizing. So that's one level. In terms of the person who has the mutation, we have to realize that we're dealing with probably the formation, spontaneous somatic mutations that occur, and that's never going to go away in biology. We actually need somatic mutations to be occurring. It's part of the fundamental biology of life. So you're not going to be able to prevent that second hit from forming. The question is, can you then target that cell in a way where you halt further progression into leading into the disease manifestation? I don't know. I mean, in an idealistic world, I'd like to think we could do that, but that's really quite a challenge. To expose an individual to a therapy that would have to be lifelong to cope with somatic mutations, you might say, well, isn't that kind of like the holy grail of cancer in general? Can we prevent cancer? I don't know that we can. I think cancer is actually part of life. But we can do a lot to deal with it. You brought up the immunologic aspects that might be involved. And we're starting to realize that we can tag into the immunology of the individual and the immune response in order to control a number of cancers. So looking at that potential interplay is an option that we have to consider. I mean, VHL is a really good model for understanding a lot of cancer biology as well.
We have a question from Alan.
maybe not.
Do you hear me? Yes.
Yes.
Thank you so much for sharing with us your experience with basaltifan. Do you think it decreases the volume of the tumor or only exudation?
That's a really good question. Well, if you reduce transudation and exudation, you're actually going to be decreasing the blood flow in the lesion intrinsically because you're getting less, there's less coming out. And you might get some attenuation of the vessel, but are you actually decreasing the number of the cells in the vessels and in the tumor itself? I would say probably not. I don't know for sure, but I actually, that's a really good question because you're probably not causing cell death that much. You're probably just stabilizing what's there more than anything else. You'd have to basically be trigger an apoptotic reaction or something, or some form of cell death. It could be other forms of cell death than apoptosis, but I don't think it does that.
Thank you. Thank you.
Hello, thank you for your wonderful talk. My first question was regarding to the belzutifan. Were there any reported adverse reactions relating to the retina on this drug?
We haven't seen it yet. We haven't seen adverse reactions in the retina. We haven't seen any compromise of visual function or anything of that sort. As I said, the major thing is anemia and fatigue. And my 12-year-old and the 19-year-old that I showed have experienced some of that. Yeah.
Professor Kaiser.
Gorin,
Oh.
great talk. My question is related to Samir. So I was wondering if you related to the anemia and fatigue. I wondered if you had cases where you had to take the patient off the drug because of the adverse events, and if so, you continue to monitor the OCT if they have a recurrence of the.
We don't have that data yet. I mean, this is new enough where Brian Shook and I are in constant conversations about whom we should take off the drug or whom we should keep on. And the tendency has been, both of us have been, keep on as long as we can. The side effects have been so relatively mild. I don't think there's anyone who's been off drug long enough to actually see a reversal yet.
I cut off Samir with more questions.
Yeah, second question. So I'm interested in machine learning. So I was thinking, have you thought of implementing it in the long run for drug efficacy, like predicting it?
Machine learning is most powerful with big numbers. This is not a big number disease. So it might be in a way if you could generalize it to other things. I suspect the oncologists who have to monitor disease progression by remote methods, such as looking at the renal cell carcinoma or the spinal and brain lesions, where they have to rely on imaging. And remember, I told you the cell mass doesn't really go away and there's this fibrotic part. It might be more relevant for them to be using machine learning to try to give them more information about the tumor, which they can't directly see like we can. So I don't think machine learning is going to help us a lot in the eye, but on other aspects of this disease, I think it plays an important role.
Are you done? Very well done, Emma.
Thank you so much for the talk. I was wondering if you or anybody has investigated the role that photoreceptors.
Which receptors?
Photoreceptors, yeah, might be playing in the development of the disease. Specifically, I'm looking for rhodopsin or encephalopsin. And those proteins are more exclusive to the retina and central nervous system.
We have not, as I mentioned before, using promoter-specific, cell-specific transgenics, they have tried to look at that, and they did not find that photoreceptors played a role in the disease. So in that sense, that's kind of the answer I have for that. That's the one cell type we're pretty sure isn't. it's unlike retinoblastoma, for example, where you get pinealomas and, there seems to be an association with sort of photoreceptor-like cells. That's a whole different thing, but not with VHL.
Hi there, thanks for your talk. In what layer of the retina do these hemangioblastomas tend to form? Because I noticed that when you deliver the AAV intravitreally, all the layers, of course, closer to the vitreous were transduced more efficiently. And so have you tried this subretinally?
Yeah, we do subretinal. We actually have done subretinal. And our initial system worked that way actually with subretinal. So we are trying to get to the other cell types. In the human, it's kind of interesting. The lesions tend to form in the outer plexiform, it seems to be. Unfortunately, by the time we see them in humans, they're usually bigger and they kind of traverse several layers. And in many cases, they're sort of rising up and outward. Angiogenesis isn't held by the boundaries of the retinal segmentation. But where they actually start, it's a very good question. When we do the histology on the early lesions, they seem to be outer.
Mr. Vice Chairman.
Yes, very exciting to see that you have a handle on the disease with the Bezaltifan. A couple of questions. You mentioned microglial ablation as a way of asking whether microglia are involved. Do you think that might have a potential therapeutic role as well? And more generally, can you say a few words about the VHL gene and where it is expressed and how you think it might be affected?
It's pretty much ubiquitously expressed. And in terms of the, as a therapeutic strategy, I can imagine, Christoph would probably have thought of this already, would be to harvest someone's microglial cells in some way, shape, or form, or precursors, fix their VHL gene, do a microglial ablation. If this is the cell type, I mean, if it's astrocytes, that's not going to work. But in theory, and then repopulate them, and that's something we actually want to test as a hypothesis. That's one reason why I like the idea of it being microglia. In one sense, I mean, I'm supposed to be agnostic. I'm ignorant, but I'm still biased. But I mean, microglia would be a really great option because you could theoretically do that. You can repopulate microglia external to the eye, and so you could theoretically do that kind of modification.
Dr.
Gorin, thanks for the excellent talk. So what's the efficiency of VHL ablation with the AAV carrying the Korean? Does that affect the phenotype?
We did not, oh, you mean to actually correct for it?
No, the ablation with the Korean.
Oh,
the efficiency and
we've not done that. That's a great question to ask when you have a model where you can reproducibly create the tumors and then you want to intervene. That was another motivation for having an animal model. Because you raise a very good point in that if you had a strategy where you target the tumor with a sort of gene-based approach for ablation, that would be a very effective way of really killing off the tumor rather than using thermal. That's a really smart idea. The problem is that's why you need an animal model, and you need one that you can reproducibly create. It's a great strategy.
Okay, Michael, I left two clinicians to torture you at the end. So let's start with ladies. Younger.
Thank you. Thank you so much for coming. I first want to say I think it's so wonderful for our patients that you're such an expert and so close by. So thank you for offering your insights, especially when multiple people are disagreeing. Secondly, have you seen concomitant improvements of the cerebellar or brainstem lesions with this medication? And is there a new adjuvant role? Have you spoken with neurosurgery for direct visualization and maybe treatment while they're in there doing?
So I don't have a lot of data from the UCLA population on the treatments. Everyone's pretty much on board using it, but I haven't actually gotten much feedback yet from the neurosurgeons. The urologic surgeons who deal with renal cell carcinoma are over the moon about it. In the paper, in the phase 2 or 3 trial that was published in the New England Journal, the response rates of the cerebellar and spinal lesions was not as good as what we, but again, as I said, I don't think their way of monitoring is that good either. I think they're really hindered by the technology. And it doesn't take much. I mean, even if there's a mild proliferative response and you're controlling the other biology of the lesions, you might not see much difference in the imaging that they're using now. I mean, you're at a center now, which is really exploring the dynamics of high resolution imaging of the retina and different cell types and looking at metabolic differences and stuff like that. You are moving light years ahead of what's going on in imaging of the rest of the body, which still is kind of at the level of MRIs and CAT scans, fMRIs.
All right, and the final comments, question.
Thank you so much for your talk. So I haven't really managed many patients with VHL, probably like, I don't know, maybe 10 in the last 10 years that I've been in ophthalmology. But when you think about ablating them with thermal approaches like the fluorescein excitation, have you any experience using infrared excitation dyes like Visidyne or?
So yeah, I tried Visidyne in the past. So for those who don't know, Visidyne was originally developed for AMD. It was crappy. It's been a kind of useful tool for central serous. Many doctors use Visidyne dye at low dose or short duration for like central serous, which probably, by the way, is ablating mast cells in the choroid. That's my theory. We could talk about central serous as well. But I did try it, and I didn't like it because I couldn't see I couldn't see a response while I was doing it. I didn't know how to titrate the dose. The beauty of using fluorescein is you literally see it. You see the fluorescein fluoresce. You see the vessels change in their caliber as you're doing it. You can see lesions that you missed light up as you're from scatter. So the fluorescein gives you a really direct visualization that lets you sort of titrate what you're doing. But I didn't find ICG was all that helpful because no one could give me treatment parameters. And when I played around with it, I didn't know where to go with it.
Okay.
Well, thank you so much.
Fantastic.
Thank you.